Um, so before I train anybody, I always remind them that suicide is not always an easy topic to discuss. We all are impacted in some way, shape, or form by it. Some of us are clinicians who may have lost a client to suicide. We may have lost family members or friends, and some folks in the room may be survivors of their own suicide attempts. And so it's important to pay attention to how you're doing at the end of the day, and to take good care of yourself, because we don't take care of the caretakers as much as we definitely need to. The other thing is that it's important not to be hard on yourself for anything that might have gone wrong in the past, or something that you find out that you should have known about, or think you should have known about or not missed, because you did what you could with the information that you had, and now you're going to learn something new. And let's look forward with this information, and we'll save lives together. So we know that suicide is a major public health crisis. I don't have to remind you of that. Almost 1 million people across the world, responsible for more deaths than war, homicide, and natural disasters combined. Across all ages, it's a leading cause of death. Every 12 minutes in our country, somebody dies from suicide, and it's now the #1 cause of injury mortality in the U.S. So more people die from suicide than from car crashes. Yet we still see lots of public service efforts at preventing car crashes, click it or ticket advertising campaigns, and don't text and drive. But we don't see that same kind of effort aimed at reducing suicide. And that's why Thomas Insel, the director of the NIMH, says it's the under-recognized public health crisis, because it's not getting the attention that it needs to get. Now, for every depressing negative statistic I share, there's going to be a hopeful counterpart, because we know that suicide is one of our most preventable causes of death. And it's an increasing issue for youth and young adults in particular. In 2010, it became the second leading cause of death in youth between the ages of 10 and 24, passing homicide for the first time. In Virginia, it's the second leading cause of death also for 24 to 34-year-olds. And some very high at-risk groups that it's been on the rise for are African-American teenage girls. It increased almost 150% over the last decade. And for our youngest kids, 8 to 12-year-olds, it's increased 150% from its lowest point in 2008. So it's not unusual these days to experience a suicide in a fifth grade class or an elementary school. Now, we know that death by suicide is really just the tip of the iceberg. In 2014, we lost 41,425 adults to suicide. But for those 41,000 deaths, there were almost 1.5 million suicide attempts, and almost 10 million American adults seriously considered suicide. So the number of people thinking about it and engaging in behaviors far outnumber the people who are dying from suicide. And there are about 25 attempts for every one death. And so we're going to talk about how we try to find out who those folks are that are at greatest risk of dying. Now, we know that suicidal ideation and suicide attempts are fairly common in our young adults from the Youth Risk Behavior Survey that the Centers for Disease Control and Prevention does every other year. And what they see time and time again is that roughly 8% will make an attempt every year, 8% of your average high schooler. And so if you take a given classroom of like 35 kids, in that classroom every year 3 of those kids will attempt suicide. Usually it's 2 girls and 1 boy, because girls attempt suicide twice as often as boys do. But boys die by suicide 4 times as often as girls. And there are 2 reasons for that. The first is that boys and men tend to choose a more lethal method, like firearms, which you could see from the Virginia data. And then the second reason is that there's much greater of a social stigma against men and boys going for treatment. When autopsy studies have been done on suicide victims, they've found almost 4 times as many women who die by suicide have antidepressants in their bloodstream than the men. So the men aren't engaging in the kinds of treatments that we know work. And there's also a strong relationship to school violence. So when the Secret Service did its Safe Schools Initiative report in 2002, it found that 80% of school shooters had a history of suicide attempts or suicidal thoughts before their attack. And a third of them reported suicide was the motive of their attack. Yet only 34% had received a mental health evaluation, and just 17% had a diagnosis. And so we've been saying since Columbine, when it was clear from Eric Harris and Dylan Klebold's journals that they had suicidal thoughts, that if we're screening in our high schools, we not only will find kids that are suffering silently that need help, but we may also prevent a mass tragedy from occurring. And it's not just in our mental health clinics that we need to look out for people who may be suicidal, but we see increased risk for suicide in all medical illnesses. So one study, for example, looked at cancer patients and found that 17.7, almost 18%, had suicidal ideation independent of any depression that they may have had on top of their cancer. And if you have any of these illnesses, high blood pressure, stroke, epilepsy, chronic pain, respiratory conditions, you increase your risk of having both suicidal thoughts and suicide attempts. So we need to do this kind of screening and monitoring in our medical offices as well as in our mental health offices. We should be looking in our physicians' offices, our pediatricians' offices, et cetera. And it's really a crisis just about everywhere. You know, it's the leading cause of death in our jails for the past 15 years, with rates of suicide 3 times that of the general population. And one thing that I learned recently was that recently released prisoners have rates of suicide similar to folks who are released from psychiatric hospitals. And it makes a lot of sense when you think about it. In both cases, they're coming out of an environment where they have support and monitoring and observation, and they're going back to a community where they have the same problems that they had when they left. And they may not have support, they may not have a job to go back to. And so it's a very high-risk time. It's also a leading cause of death in our first responders themselves. Law enforcement officers, it's a leading cause of death in law enforcement officers, and it's a leading cause of death in firefighters. We lost more firefighters to suicide than we lost in the line of duty in fires. And so we train first responders how to ask these questions all the time, and they tell us that they're not just happy that they have the questions to use in the community, but they're also happy to have the questions because then they can screen their partners and they can screen themselves. They know what to look for in themselves if they're going to worry. Now, while the greatest numbers of suicides are in our cities because of the population density, the greatest rates of suicides happen in the rural parts of our country. And that's because they have populations that are spread out across great distance. They tend to have less consistent access to medical and mental health care. Sometimes the closest physicians can be, an hour or 2 away and are usually overburdened. And when I was the director of youth suicide prevention in Georgia, we saw just that when families had somebody who was out of work and they couldn't afford the gas for their cars, they didn't take their kids to their mental health appointments. It just wasn't a priority for them. Now, the other thing about the rural parts of our country is if you track all of the demographic factors against suicide, age, gender, race, socioeconomic status, education, the one demographic factor that most closely tracks alongside with suicide rates are rates of gun ownership. So you can see on this bottom chart that the states that have lowest rates of gun ownership, California, Illinois, New York, New Jersey, Connecticut, Massachusetts, Florida, they all also on the top chart have the lowest rates of suicide. And this study looked at taking the 5 states with the lowest rates of gun ownership and comparing them to the 15 states with the highest rates of gun ownership, so that you would have population samples that were equal of 200 million residents. And when they did that, the states with the low rates of gun ownership, or 15% of households owned guns, the numbers of non-firearm suicides were the same in both groups, roughly 6,500 men and 2,500 women. But when you took a look at firearm suicides on top of that, the numbers of firearm suicides of men in states with low rates of gun ownership, just 4,000, and the states with high rates of gun ownership were 14,000, so a fourfold difference. And in females, 286 in the states with low rates of gun ownership and 2,200 in the states with high rates of gun ownership. So just having access to the potential lethality of guns increased the numbers of suicides of women by almost doubling them in the states that had high rates of ownership compared to the low rates of ownership states. Now, we train often in states that are very pro-gun. I've been to El Paso, Texas twice this year, and Anchorage, Alaska. And, you know, what I tell people is that, you know, we're not against gun ownership, but we are for gun safety. It's very important that when you have somebody who's at risk of suicide, you make sure that they don't have access to firearms. Now, depression is on its way to becoming the most burdensome disease in the world. WHO predicts it will by the year 2030. It's already the most burdensome disease in our country and other middle and high-income countries, and that makes it the #1 cause of work-related absence in the U.S. So more people call out of sick work for depression than for having the flu or having a kid who's sick. And that costs our workplaces $23 billion a year in lost productivity from just those days missed. It doesn't even count the people who are coming into work with low-level depression and just not working up to their potential. So not only does depression impact families and individuals, but it also has a strong impact on our economy as well. Now, unfortunately, people who need treatment don't get it. We know that 90% of those people who die by suicide have an untreated mental illness, and 60% of it is depression, but the undertreatment of mental illness is pervasive in our country. 50 to 75% of those in need of treatment receive no treatment or inadequate treatment, and for kids, it's towards that high end. 70% of kids and teens with depression go untreated. And over 80% of teenagers and college students who die by suicide never received any consistent treatment prior to their death. So we're not identifying who needs help, and we're not getting them the help that they need. Now, I always go over some myths about suicide that can get in the way of doing good suicide prevention. The first is that if somebody's really suicidal, they're probably going to kill themselves at some point no matter what you do. You just can't stop people who want to do it. And we know that this is false because multiple studies have shown that more than 90% of people who make even the most serious attempts don't go on to die by suicide later in their life. Death by suicide is actually quite rare, and that goes back to the statistic I shared earlier about there being 25 attempts for every 1 death. And that's because also most people are suicidal for just a short period of time. It's one of those symptoms that comes and goes with levels of stress. And so if you help somebody through that time of peak crisis, they may never become that suicidal ever again for the rest of their lives. So you actually may make a difference and save a life for forever. Asking a depressed person about suicide may put the idea in their heads. We know that this is false as well. When I graduated from social work school, I remember my first job was working in an inner city community mental health clinic with adolescents in Boston. And I was terrified to ask the kids that I saw, have they ever thought about killing themselves or have they ever tried to kill themselves? I was afraid that, they were all of a sudden going to believe that it was an okay thing to do because I talked about it. We know from the last decade of research that talking about suicide with people does not increase the risk at all of them engaging in those behaviors. Even when an entire high school of kids is screened, it does not increase the risk of any of those kids of having increased thoughts or behaviors. In fact, open discussion is more likely to be experienced as relief than as intrusion. And of course, the risk is when we don't ask, when we think we should. And there's no point in asking about suicidal thoughts if someone's going to do it, they won't tell you. We know that this is false as well. Many people will tell a clinician when you ask them, although they might not have volunteered it on their own, and they are often relieved when they can. And that's because ambivalence is characteristic in 95% of people who are suicidal. The wish to die fights against the human species' natural instinct to want to live. And that battle is going on constantly in people who are suicidal. It's actually very, very difficult to overcome that will to live that is innate in us. And so when people are feeling more stressed, that wish to die becomes stronger. But there's always an ambivalence. And that's why people want to be asked these kinds of questions, and why we see contradictory statements or behaviors common to people who are suicidal. I heard a story recently about a man who had made a suicide attempt, and he also in that same week booked a family vacation. So while he was thinking about his own death and not wanting to be there, he was also thinking about something in the future. And so that's the kind of contradictory behavior that we see often. And many folks will give some hints or warnings to friends or family, even if they don't tell a clinician. Because, again, that will to live wants to be asked and wants to be rescued. And I can recall a private high school that we worked with up here in New England. And they had a young man that they lost to suicide. And he told his friends, tonight after the lacrosse game, I'm going to go home and I'm going to kill myself. And his friends, didn't know to take him seriously and didn't believe him. But most people will give hints or warnings on social media or tell somebody. Somebody making suicidal threats won't really do it. They're just looking for attention. We know that this, too, is false. People who talk about suicide or express thoughts about wanting to die are at risk, and they do need our attention. While we know that 80% of people do give some indication or warning, even with those people who will talk about it quite frequently or who have sort of a baseline low-level depression that makes them wish they were dead, this is sometimes common in folks with borderline personality disorders, that we take them seriously every time they say these kinds of things because it's very possible that the time that we don't listen to their cry for help and help them will be the time that they feel that they weren't heard and become hopeless and then make an attempt. And then if you stop someone from killing themselves one way, they'll probably just find another. This is the argument for means safety as being the most evidence-based suicide prevention method that we have. And means safety is when you put a little bit of extra time between someone who's acutely suicidal and them having access to the lethal means that they're going to use. So we know that firearms are lethal 85% of the time that they're used in a suicide attempt. Suffocation or hanging is lethal 69% of the time. And falls, poisoning, overdose, cuts are lethal much less frequently. And we have lots of examples of places where just reducing the access to lethal means results in lower suicide rates in general. So in the United Kingdom in the late 1950s, they used to use a coal gas in their ovens that was highly toxic. It had a high carbon monoxide content, and people were killing themselves by asphyxiating themselves on that gas. And that's where the expression, put your head in the oven, comes from as a euphemism for suicide, if you're old enough to remember that like I do. And they started phasing that gas out in the late 50s. And they saw a reduction in suicide by carbon monoxide poisoning by a third without seeing an increase in other methods. So when people thought, this is how I'm going to do it, and it didn't work, that gave time for that ambivalence to then spark up, and they were able to get some help and ended up not dying. We also saw it again in England in the late 90s. They were having a problem with Tylenol overdoses. and they introduced a law where they have to sell Tylenol in individual blister packs where you punch out one pill at a time, like we have with sinus medication here in our country. And when they passed that law, they reduced overdoses in Tylenol by 44% over the next decade. So just because it took a few extra minutes to get a handful of Tylenol, people weren't overdosing on it. In our country, we sell Tylenol in bottles of like 500 at Costco, right? We don't have the same kinds of efforts at legislating means restriction. And then numerous examples of how reducing access to firearms reduces suicide rates, from required locked storage in New Zealand, which reduced the gun suicide rate in youth by 66%, to the Israeli military, which in 2006 decided they were going to restrict their soldiers' ability to take their guns home on the weekends. And when they didn't have their firearms at home, when they were getting into emotional struggles, they were able to reduce suicides in their military by 40%. And that's why we're working now in partnership with the Department of Defense and the NRA to get these CSSRS questions into gun and sporting shops, into firing ranges, for firearm safety trainers, and at gun shows. Because we know that half of all suicides are done with a firearm, and 2/3 of all gun deaths in our country are suicides. Twice as many suicide deaths by guns as homicides by guns. So we know that suicide is preventable. We know that we can use means restriction, we can use psychopharmacology, and we can use psychotherapy, CBT, those kinds of treatments. But first we have to identify who needs help. And the problem for many, many years in the field of medicine has been not having common definitions for suicidal behaviors. So you would see the same exact behavior, and it would be called 10 different things. It would be called suicide threat, suicide gesture, non-serious suicide, parasuicide, all without having a good understanding of what kind of risk was to be associated with those terms. And that had negative implications not only on the individual not knowing who needed help and what kind of help to give them, but it also impacted our epidemiological data collection. Right? If we weren't calling things by the same nomenclature, how could we compare one school to another school, one hospital to another hospital? Right? And the research and the data was all wrong. And that's why the Institute of Medicine in 2002 said research on suicide is plagued by the lack of uniform definitions. And so the Columbia has actually gone a long way towards unifying the definitions surrounding suicidal behaviors. It was actually developed about a dozen years ago as part of the first National Institute of Mental Health study looking at the treatment of adolescent suicide survivors, those who have made suicide attempts. And it was called the TASA study, Treatment of Adolescent Suicide Attempters, and it was a study done multi-site by Columbia and Aaron Beck's group at the University of Pennsylvania and University of Pittsburgh. And they brought together all of the scales that they could find for their research, and they realized that there was no scale that could look at suicidal thoughts and behaviors in the same scale, and no scale they could use to measure the number of times people had done things, and no scale that they could use to see if someone was getting better or worse and track change. And so they took their 20-plus years of individual suicide research knowledge and brought together the questions on the CSSRS so that you would have the minimum numbers of questions that you would need if you were in a school or a hospital or a jail that you could ask to somebody that would provide scientifically based information to inform your clinical judgment and make a decision about somebody's risk level. It's since then been used tens of millions of times. It's available in over 100 languages here at our center. and it takes a very brief time to administer. I'm going to be going over with you today both the short screener version, which is just 2 to 6 questions, and the longer full version, which is just 10 to 25 questions. Both take mere minutes on average to administer. It's deemed now the most evidence-supported tool available, has excellent acceptance by patients and providers, and it's used across all ages. So we've seen it used effectively with kids as young as 6 and adults, up to 106. And it's used for lots of different special populations as well. So you're going to see later on why it's so possible and effective to use with even folks who have communication issues. So remember I said the definitions were a big problem. Well, the CDC has adopted the Columbia definitions as their recommended set of definitions for anybody who's doing research now on suicide, and they have a document for suicide researchers that they link to our website for definitions. But they also have a list of unacceptable definitions, things we should stop saying, things like suicide gesture and threat and parasuicide that we still see from time to time, but also things like completed suicide and successful suicide, right? You complete a project and you're successful at your job, and we want to take the positive word away from something like suicide. So the only appropriate way we think to talk about suicide are to talk about suicide attempts, attempted suicide, and died by suicide. It's very hard to change culture, and so we still see quite a bit of completed suicide, but we're working hard to move the needle and make that change. Now, we really believe that everyone everywhere can ask the short screener questions. You don't have to have any mental health training. There have been studies that have been done that showed that nurses with no mental health training did it reliably. Correctional officers in a juvenile justice facility did it with good inter-rater reliability. And so when we train in schools, we like to train everybody who works there, from teachers to coaches to bus drivers and cafeteria workers. In healthcare settings, we like to train receptionists and even custodial and janitorial staff. We were training in Connecticut in one hospital. We were up there, said to us, we train everybody, including our janitors. And this other person said, that makes sense, because we had somebody who was hospitalized and the only person he ever spoke to was the janitor cleaning his room at night. And that's who he felt connected to. And so we're not training those folks how to be mental health evaluators, but for them to have, know the right questions to ask if they, are a little bit worried about someone, and then know the next steps that they can take if they have these worrisome answers. What are the worrisome answers? And so we now have these cards that are being distributed to our U.S. military personnel so that they can ask these questions to each other. They're called our ACE cards. ACE is a military program that stands for Ask, Care, and Escort. And so every military person in the Air Force, every airman is going to get this card, as well as their spouses. It's got the SSRS questions on the back, the 6-question screener, and it highlights for them in red what the high-risk answers are and tells them, what next steps they should take. We have these for communities, for kids in high school to ask their friends, all different applications of peer-to-peer identification. And, you get the most bang for your buck when you link systems from a top-down model. And it used to be that we would just hear from a single hospital in a community, but now we're starting to hear from lots of governments, like the departments of behavioral health or mental health. And when you can initiate training provider by provider in all services, between services, and in all systems of care in a community, that's when you create the strong safety net underneath folks. Right? When you have hospitals and primary care and law enforcement and justice and schools, and they're all speaking the same language by knowing what the SSRS is, that's when you quicken care to people who need it. someone we were training said, I think I get it. When the school nurse is doing the same assessment that the EMT knows, that the admitting nurse knows at the hospital, I'm going to get that kid the help that they need, much faster. And we're actually seeing reductions in actual suicide rates, which is very, very hard to accomplish. But states that are embracing the zero suicide model are actually doing it. Utah reported in 2014 their first reduction in suicides over the last decade. They've made their state a zero suicide state and have implemented the CSSRS and safety plan intervention across a wide variety of institutions, from their fire authority to their domestic violence advocates to their schools, and made it part of their Medicaid improvement plan. But even in individual programs like Centerstone, for example, Centerstone is the nation's largest provider of community-based behavioral health care, and in just one state, Tennessee, within 10 months of using the CSSRS, they saw a 64% reduction in their outpatient suicides. And in the military, the Marines were our first example of a branch that we worked with, and in the Marines, they trained all support staff and resulted in an 18% reduction over 2014 and 15 compared to the 2 years prior. But what's interesting about the Marines is that they didn't train their behavioral health staff. They trained their clergy, and they trained their sexual assault and substance abuse workers, and they trained their lawyers and their legal assistants. Because actually the number one precipitating event before a Marine suicide is having a legal issue. So they get arrested on a DWI or a drunken disorderly or domestic violence charge, and they're ending their lives by suicide because of the impact that that has on their career. And so now in the Marines, every time a lawyer meets with a Marine, the lawyer asks the screener questions and then takes them to behavioral health if they have a worrisome answer. And so I always share that with audiences because I want you to think about who are the gatekeepers in your community that are in close contact with people when they're in crisis. And, how can we get them involved in this kind of education and training? We also heard recently from one of our state psychiatric hospitals, Buffalo Psychiatric, which reported to us that every year before becoming a zero suicide hospital, they were experiencing 1 to 3 suicide deaths. But since becoming a zero suicide hospital, knock on wood, they just completed their 3rd year without a suicide. So some very exciting, preliminary results coming back. And being a zero suicide state or hospital is a result of participating in the National Action Alliance's Zero Suicide program or model. And they have a website where they have lots of resources. But the zero suicide model came out of some work that was done in New York State evaluating recent suicides. And what they found when they evaluated them was that they had no risk assessment done, they had no safety plan written, and they had no warm handoff. So they were dying in that very high-risk time after being discharged from an ER or an inpatient unit before they were getting set up with their outpatient treatment. And so the CSSRS is one part of the intervention for the risk assessment piece. And then safety plan writing is the intervention for not having a safety plan and not having a warm handoff. So the safety plan that's recommended is the safety plan that was written by doctors Barbara Stanley and Greg Brown. Barbara Stanley, she's here at Columbia, and Greg is Aaron Beck's PI at Penn. And it was developed initially for use in the VA, but has been adapted for civilian ED and all kinds of use. And what it does is it gives somebody, when they leave your facility, something they can take with them in case they become suicidal again, and it gives them steps that they can take that are personalized that can help them to de-escalate the next time they feel suicidal. A very effective intervention. So Centerstone, what they do is they have a suicide-safe pathway that they place their high-risk patients into. And every patient is screened using the screener at every service delivery point that they have. So if you have a med management appointment and group therapy and an individual appointment, you'll get screened 3 times in a day. And that's so that they don't miss anybody who may develop these types of thoughts or behaviors. And then if they screen high, they get placed into the suicide safe pathway, where they get weekly appointments and psychoeducation about means restriction. And if they don't show up for one of their appointments, they get placed with a follow-up specialist who continues to reach out by phone until they can re-engage them in their treatment. And they bring it home by talking about one man who had not shown up for an appointment, and they were calling him and calling him and calling him. And finally, he came back in and told them, the last time you called me and asked me those questions, I was on the bridge. I was thinking about jumping. And, this system has actually saved them. And we really believe that we need to monitor for suicide the same way we monitor any other vital sign, because we know that people who die by suicide, half of them almost have seen their primary care doctor in the month before they died. Many adolescents who have made suicide attempts come to the ER for accident or injury, and they don't get screened for psychiatric issues. And so we know that if we ask, we can find them. And we know that screening works. Evidence has shown screening in high schools, screening in colleges, screening in primary care all increase the rates of detection and diagnosis and treatment adherence. And so the Joint Commission is promoting the CSSRS for screening. And they say, when the ED is asking their set of questions and the social worker asks another set and then the psychiatrist asks another, you're reducing signal strength. You're not honing in on the needle in the haystack. And that's what having this common language of the CSSRS really helps to do. And so the first hospital to implement universal screening has been Parkland Hospital in Dallas, Texas. And they screen every single individual who comes into care there. And they report that of their first 100,000 patients they screened, they found 1.8% of them needing next steps based on CSSRS information. And this is, they say, helping them find people who don't come in for psychiatric reasons. So let's talk about what the CSSRS is and how to use it. So the CSSRS is simply an assessment of suicidal ideation and suicidal behavior. It begins with an assessment of ideation severity, and that's 5 questions that increase in severity as you move from question 1 to question 5. It starts with a wish to die and moves to an active thought of killing oneself with plan and intent. Then, if you're doing the lifetime recent, you have a second section where you'll answer 5 intensity questions about the highest level they achieved on the first part. And then you have behaviors. Now, the behavior section for the first time assesses all relevant behaviors. It used to be that we just asked people, have you ever attempted to kill yourself? And then we missed the people who practiced tying a noose in their basement or who went online and researched painless ways to kill themselves. Things that we know now have just as much risk as a past suicide attempt for making another attempt, but were things we didn't ask. And the CSSRS has all of the definitions for those behaviors as well as standardized probe questions to make it very, very easy for you to ask. Then finally, if you're doing the full version, there is a lethality section for any actual suicide attempts that they made, how much medical damage happened from them. So it's a semi-structured interview, which means that there are probe questions for all of the items, but you don't have to ask any or all of the questions as long as you've asked enough questions to figure out how to score this particular person, figure out if something is suicidal in fact or not. And when we get to the definitions of all of these behaviors, you'll get a sense of what that's like. But most people start out with reading them from the scales themselves. But once you get familiar with what you're trying to gather information-wise, you can make the questions feel a little bit more, personal in your style. Again, as long as you're collecting what you need to collect to properly fill out the forms. Now, one of the great aspects of the CSSRS that's different from other scales too is that you don't have to just rely on an individual's report of what they've experienced. Most of the time, the person who you're interviewing is going to give you the best information, but if they can't or they won't, then you can use information from other sources like family members or caregivers or past records. This can be very helpful for kids and adolescents who may not tell you the same story that their parents tell you. It also is the reason why the scales are so effective in their use with Alzheimer's patients and with autism, because if the patients are unable to answer these questions, then they get asked of the caregivers, and they ask the caregivers, so did you hear him say anything like this during the week, or did you see him do any of these kinds of things? And so you can use caregivers or past medical record information. So, a good example of that is a client comes in for intake and denies any lifetime suicidal ideation or behavior, but the medical record that you got sent over from another hospital indicates that they had a recent suicide attempt where they had an admission. And then you can use the medical record to complete the CSSRS if they're not telling you what you need to know. So the ideation section on the full version is the front page. It's 10 questions in 2 time frame columns, lifetime and recent, and we'll talk about those in a bit. And the screener starts with the same first 5 questions. And so it begins with, have you wished you were dead or wished you could go to sleep and not wake up? And then, have you actually had any thoughts of killing yourself? If that second question is no, then you can skip to the next section. But if that second question is yes, then you ask, have you been thinking about how you might do this? Have you had these thoughts and had some intention of acting on them? And have you started to work out or worked out the details of how to kill yourself? And do you intend to carry out this plan? You can't have a method in mind or intent to act or a plan and intent if you've never had a thought before, which is why for moving more quickly, you can skip 3, 4, and 5 if question 2 is no. And the data that came back when they were, first piloting the scale, showed clearly that as you increase in the severity of thoughts, you also increase in the risk of making a suicide attempt from an odds ratio of 5 up through an odds ratio of close to 19.
So tell me, what brings you to see me today?
I've been feeling kind of crummy. Problems with my family and things at work aren't going so well.
Have you been feeling depressed?
No, I've been crying a lot, and it's hard to get out of bed in the morning. I guess you could say I'm depressed.
I see. So tell me, over the last month, have you wished you were dead or wished that you could go to sleep and not wake up?
Sometimes I think things would be better if I were dead.
I understand. But do you actually wish you were dead or want to be dead?
Now and then, yeah.
And have you actually had any thoughts of killing yourself?
Yeah.
And have you been thinking about how you might kill yourself?
Sometimes I think about jumping in front of a train or a bus.
But you wouldn't really do that, though.
No way, no way.
See how asking the wrong question can shut down the conversation? Watch now how asking the right questions using the prompts on the CSSRS can get you more accurate information.
Sometimes I think that I'll jump in front of a train or a bus.
Have you had these thoughts and had some intention of acting on them?
Yeah.
Can you tell me a little more about that?
Last week I really wanted to do it, but I chickened out.
Okay, so have you started to work out or worked out the details of how to kill yourself?
No, nothing specific.
Thank you for being so honest with me.
Thank you.
So in the example you just saw, the answer circled would be a 4, intent only, not intent and a specific plan. In this next example, a 5 would be indicated. Watch.
Sometimes I think that I'll jump in front of a train or a bus.
Well, have you had these thoughts and had some intention of acting on them?
Yeah.
Can you tell me a little more about that?
Last week I really wanted to do it, but I chickened out.
Okay, so have you started to work out or worked out the details of how to kill yourself?
Yes. I got a subway schedule and I saw that there's a station that between 7 and 8 o'clock at night, there aren't many people there, and that's what I was going to do.
Well, do you intend to carry out this plan now?
I worry that I might.
Okay. Thank you for being so honest with me. We're going to get you some help right now.
Thank you.
You see, it would be a 5 because he had intent and a specific plan with the intent to act on it, all the details worked out, etc.
So is this a method or a plan? This patient reported he first started thinking about killing himself when he was 12, and he thought about how easy it would be to pretend to fall in front of a bus before it was able to stop so it would look like an accident. Although he thought about it often, he said he didn't have the courage to do it. Is that ideation with a plan, or is that ideation with a method? That's ideation with a method. A plan has to have more detail. So a plan would sound something like, next Wednesday at 3 o'clock when my mom works the late shift and she won't be able to come home and stop me, I'm going to take all of the pills that we keep upstairs in the medicine cabinet. It would have the what, the where, and the when of what they were going to do. And that's what makes it a plan. So if you're doing the lifetime recent, the full version, after you've assessed the highest level of severity that they endorse with a positive answer, you're going to ask these 5 follow-up questions about that highest level time. You're going to ask about the frequency of the thought, the duration of the thoughts, how controllable those thoughts were, whether they have deterrence to acting on the thoughts, and what the reasons are for the thoughts. Is it to stop the pain they're in, or is it to make something else happen? And all of these items, too, have significant predictive value for making a prediction about suicide attempts. For frequency, you ask how many times have you had these thoughts, and there are multiple choice answers that you can select the one that most closely matches what the client or patient says. For duration, when you have the thoughts, how long do they last? For controllability, can you stop thinking about killing yourself or wanting to die? How easy is it or hard? For deterrence, are there things, anyone or anything, family, religion, fear of death, pets that stop you from wanting to die or acting on your thoughts? And what sort of reasons did you have for thinking about wanting to die or killing yourself? Was it to end the pain that you were in, or was it to get attention or revenge or reaction from others, or some combination of both? And so it makes sense intuitively that if thoughts are more frequent, if they're longer in duration, if they're less controllable, if they have fewer deterrents to acting on them, and if it's to stop pain, then you would be at greater risk. And so you can add up the multiple choice numbers on this section, and it will give you a score of somewhere between 2 and 25, and you can use that score to help inform your clinical judgment about risk. We don't have cutoffs for the score in this particular section, which is why it's not part of the short screener, but it can be a really good section for use in monitoring whether someone is improving or not, because if you saw improvement, this score would, definitely come down or go up if they were getting worse. Of interest, if you work with adolescents, is that Dr. Cheryl King found that the second question in this section, the duration question, was the most predictive question for teenagers. So for teenagers, if they're having suicidal thoughts and they're lasting all day long, they can't stop thinking about it. That's when risk is greatest for that age group. So after we've asked about ideation, we move on to asking about behavior. And behavior asks about 4 specific behaviors. And each of those behaviors has an odds ratio roughly equal to 5. Each behavior puts someone 5 times more likely to have an additional behavior. And we also see that as you add behaviors, your odds of making an attempt also increase. And so the definition that we have and the CDC has for a suicide attempt is a self-injurious act undertaken with at least some intent to die as a result of the act. And there are 3 important bars that must be met. The first is that it says self-injurious act. It doesn't say self-injury. There actually doesn't have to be any injury or harm, just the potential for injury or harm. So if somebody puts a gun to their head and the gun fails to fire because it's broken or jammed, as soon as they pull that trigger, the potential for harm is there and it becomes a suicide attempt. There doesn't have to be any injury. The second thing is that it says with at least some intent to die, with some being the important word. As long as intent to die is non-zero, it qualifies as a suicide attempt. You know, people often have mixed motivation in making suicide attempts. But as long as a little bit of them wanted to die, we call it a suicide attempt. And it can be that 99% of them did it because they wanted to make their mother mad, but 1% of them wanted to die when they did it, and that would qualify it as a suicide attempt. And then finally it says, as a result of the act, meaning that the intent to die and the behavior must be connected. They must be doing that behavior in order to make themselves dead. You know, someone once asked me, what about people who are doing very high-risk behavior, like drugging excessively, driving at high speeds? They don't care if they live or die. Are those people making suicide attempts? And the answer is, with a strict definition like this, they would not be making suicide attempts because they would not be doing those things in order to bring about their death, right? That doesn't mean that those folks don't need treatment and help. They do for their risky behaviors, but we're trying to really nail down whether or not something is a suicide attempt or it is not, and those, in fact, would not be considered suicide attempts. Now, another aspect of the CSSRS that's different than a lot of scales is that you can infer intent in 2 different ways. The first is that if somebody denies that they have intent to die, but that they know that what they did could be lethal, you can infer that it was a suicide attempt. Or if there are clinically impressive circumstances. That's where what somebody does is so highly lethal that it's obviously a suicide attempt and couldn't be anything else. That's someone who shoots themselves in the head or takes 200 pills or sets themselves on fire, things that to any lay individual would be considered a suicide attempt. And, you know, the importance of being able to infer was made from an Army hospital that we trained, and they told us about a soldier who had been hospitalized after he shot himself in the face and survived. And when he was able to speak, they asked him, were you trying to kill yourself when you did that? And he said no. And what they told us was if they couldn't infer from the CSSRS, he would never have had a suicide on his medical record, and he would never get the treatment that he, you know, deserved and needed. So a suicide attempt will begin with the first pill swallowed or the first scratch made with a knife, and the questions are, have you made a suicide attempt, or have you done anything to harm yourself, or have you done anything dangerous where you could have died? And those first couple questions will get you started on the conversation of finding out if there were any suicide attempts. And the reason why this section is the only one with these multiple probes is because we're really trying to tease out whether a self-harm behavior was a suicide attempt or was it non-suicidal self-injury. Now, non-suicidal self-injury happens when someone engages in self-harm behavior and it's 100% purely for reasons other than to end their life. It's usually to accomplish one of 2 things. to change how they feel internally. So they're feeling a lot of pain, and cutting or burning their skin helps release that pain, or they're feeling numb inside, and self-harm behaviors release adrenaline, which makes them feel alive or present, and or changing external circumstances. That's someone who wants to get sympathy or attention or make somebody else angry, or somebody who wants to be hospitalized because they know that it'll get them a warm bed and some meals if they're homeless. If somebody goes to the ledge of a roof and pretends they're going to jump because they want people to feel sorry for him, and they trip and fall off the roof, we would have to call that an accidental death, right, if we knew that he had no wish to die when he went up there and he was only up there for this other reason. So is this a suicide attempt, yes or no? This patient wanted to escape from her mother's home, so she researched lethal doses of ibuprofen, took 6 ibuprofen pills, and said she felt certain from her research this was not enough to kill her. She said she didn't want to die, only to escape from her mother's home. So she was taken to the emergency room where her stomach was pumped and she was admitted to a psychiatric ward. Do you think that's a suicide attempt? Yes? No, or not enough information? No, it's not. She researched it and didn't want to die, and intentionally took what she knew or felt was a non-lethal dose. Now, this was a girl who was hospitalized at Columbia, and all over her chart it said that this was a suicide attempt. And it wasn't until Dr. Posner took a little extra time to ask a few important questions about why she did what she did that we got better information about what was going on. This girl also had suicide attempts in the past, and I think people assumed that because she had made past suicide attempts that this must also be a suicide attempt. And it's really important that we do this right every time, because we need to know if her most recent suicide attempt was 2 days ago, or was it 2 years ago, or has she had 2 attempts in her lifetime or 20? Right, so we need to really be careful and ask the right questions and get it right every time. This young woman, following a fight with her boyfriend, felt like she wanted to die, impulsively took a kitchen knife and made a superficial scratch to her wrist. Before she actually punctured the skin or bled, however, she changed her mind and stopped. Yes, no, or not enough information? Yes, she had a wish to die. She wanted to die, and as soon as she made that first scratch, that made it a suicide attempt. The patient was feeling ignored. She went to the family kitchen where her mother and sister were talking. She took a knife out of the drawer and made a cut on her arm. She denied she wanted to die at all, not even a little, but just wanted them to pay attention to her. Yes, no, or not enough information? No, she didn't want to die, not even a little, so there's no intent. The patient cut her wrists after an argument with her boyfriend. Yes, no, or not enough information? It's not enough information. We know what she did and that there was an emotional argument, but we don't know, if there was any intent to die when she did it. Had a big fight with her ex-husband about her stepson, took 15 to 20 imipramine tablets and went to bed. Slept all night till 4 or 5 the next day. Says she couldn't stand up or walk. Called EMS and was taken to the ER where she drank charcoal and was admitted to the hospital. She couldn't verbalize clear intent, but says she was well aware of the dangers of a TCA overdose and the potential for death. Yes, no, or not enough information? Yes, we can infer it because she knows that a TCA overdose could kill her. Now you'll see this is the actual attempt section on the form, and there's that question in the red box, or did you think it was possible you could have died from? That can remind you that you can infer. And you'll see the question at the very bottom says, has subject engaged in non-suicidal self-injurious behavior? Now the reasons the author put that question there was because they realized that if you asked a whole lot of questions about a self-harm episode and determined it was non-suicidal, if that wasn't there, you would just have a no checked off for actual attempt. And you wouldn't be able to know that you asked all the right questions and determined that this, self-harm episode was in fact non-suicidal. Now the other behaviors that we assess are an interrupted attempt. That's when someone starts to take steps to end their life, but someone or something stops them. So they have a bottle of pills in their hand, and someone grabs it from them, or they're on the ledge ready to jump, and the police officer wrestles them back in the window. And the question is, has there been a time when you started to do something to end your life, but someone or something stopped you before you actually did anything? And then we have aborted or self-interrupted attempts. That's when a person begins to take steps toward making a suicide attempt, but they stop themselves. They change their mind before they actually engage in any potentially self-destructive behaviors. And so that's somebody who is planning to drive their car off a certain cliff, and before they get there, they turn around and come back home. Or someone who picks up a gun and is thinking about killing themselves and then puts it back down. And the question to ask is, has there been a time when you started to do something to end your life, but you stopped yourself before you actually did anything? You know, people won't consider that a suicide attempt because, you know, they stopped prematurely. And so if we just ask them, have you ever tried to kill yourself, the answer will be no. And that's why this question is so important. The importance of this question also came to us from a hospital we were training, and they told us about a man, and he had driven his car into a wall as a suicide attempt. And when they asked him this question, he said, you know, yeah, there were 4 other times I drove really quickly toward that wall but stopped before I got to it. And no one's ever asked me a question like that before. Now, you know, imagine if a week before the crash, he had been in to see his primary care doctor, and his primary care doctor had known to ask this question. Maybe they could have avoided the actual attempt. And then finally, preparatory acts or behavior. That's any other behavior beyond a verbalization where there's suicidal intent. That's like collecting or hoarding pills, purchasing a gun with the intent to use it in a suicide, writing a suicide note, going online and investigating ways to painlessly kill yourself. And the question you can ask is, have you taken steps toward making a suicide attempt or preparing to kill yourself, such as, and a bunch of the examples are right there in the question for you. And this question's importance was made by the VA hospital in Detroit that we were training. And they told us about their most recent suicide. A 70-something-year-old veteran had been in to see his treatment team, denied their usual questions. But upon his death, they found that he had been putting clothing in different bags and labeling it for charities. He had been stockpiling food for his pet. For 6 months, he was making these preparations for his suicide. And, you know, what this told the system was, that, if they had known to ask this question, there was potential, for them to avoid his death. Now, these graphs point out 2 really important things about the CSSRS. The first thing that they point out is that people, say to us all the time, if we screen every kid that walks in the school or every kid in, this jail, aren't we going to have so many people to worry about that we're going to have lines outside the social work department doors and be here all weekend working? And the answer is that consistently what we see is that it's less than 2% of people who have these worrisome answers. So this top graph is a look at 30,000 administrations of the CSSRS to depressed study subjects. And of those 30,000, just 1.7% had what we would consider a worrisome answer. And the bottom chart is a look at that same Detroit VA hospital, where they said, we're a VA hospital, we have such high-risk patients, we're not just going to get 2% if we start screening. So they screened their vets that were coming in to see a psychiatrist, so they had a mental health diagnosis. And when they screened 3,000, almost 3,000 of these vets, they found 0.5% screening positive, and of those 14 that screened positive, only 5 of them required hospitalization. So they had very, very few that needed help. The other thing that these graphs show, this top graph shows, is that of that 2% that had worrisome answers, only 13% of them had actual attempts, and 87% had these other 3 behaviors that we didn't used to ask people about. So if all you do ask about is actual attempts, you're going to miss the vast majority of people who have these worrisome answers. Now, classification of any kind at times can feel like splitting hairs, and we love to get examples sent to us where people say, what would you classify this as? This was one that was sent to us, an adolescent who had tied a noose and he put it over his head, and just then the phone rang and it was his friend, and after he talked with his friend he felt better and changed his mind. Is this an interrupted attempt because the friend called, or is it an aborted attempt because he changed his mind? We think it would be an aborted attempt, maybe unless the friend actually talked him out of killing himself. But you know what? In either case, whichever you chose to call it, you would have a worrisome behavior on your form, and that's what's, in the end, the most important thing. So a few more examples about these other behaviors. This patient stated she experienced heartbreak over the loss of a guy a week before the interview. So she took 4 clonazepam, called a girlfriend, and cried it out on the phone. She was dismissive of the seriousness of her attempt, but she indicated that she wanted to die at the time she took the overdose. Is that a suicide attempt? Is it interrupted or aborted? That's a suicide attempt. She wanted to die when she took the extra pills, and as soon as you take 1 pill, it becomes an attempt. During pill count, staff discovered 6 tablets missing. Upon questioning, the patient admitted she was saving them up so she could take them all together at a later time in order to kill herself. Is this interrupted, aborted, or a preparatory behavior? Obviously, it's a preparatory behavior, the very definition of them. Several weeks after being informed by her husband that he was having an affair, the patient went to Haiti to see him to discuss the situation. She became enraged during their discussion and grabbed his gun with the intention of shooting herself. However, her husband struggled with her, took the gun away, and before she could pull the trigger, and hid it from her. Says she was feeling pain and hurt and that she was so upset she wanted to die. Is that a suicide attempt? Is it aborted or interrupted? It's interrupted because he took the gun away from her before she could pull the trigger. The voice commanded the patient, age 18, to jump from the roof. Although the patient went to the roof, he did not jump. Is this aborted, interrupted, or a suicide attempt? It's aborted. You may have noticed that one of the slides earlier said that auditory hallucinations do qualify as suicidal ideation when they're suicidal in nature. This, was clearly his own self telling him not to jump. This patient was feeling despondent about her financial situation. Her rent was due and the landlord had threatened to evict her. She went to the bathroom and took a razor from the cabinet, cut one of her wrists, and began bleeding. She bandaged up her wrist herself, and during an interview a week later, she said she had never cut herself before. She was adamant that she did not need to be hospitalized. Is this a suicide attempt, non-suicidal self-injury, or not enough information? It's not enough information. We know that she cut herself and that she was feeling despondent or bad. But we don't know if she had desire to die when she did that. So we need to ask a few more questions. So if you're doing the lifetime recent, you have this final section on lethality, and that's where you can put, if any actual attempts occurred, what was the medical damage that happened? So if it was a cut, you'll ask a couple questions about, did it bleed a lot or a little? Did you have to get a bandage? Did you go to the hospital? Did you lose so much blood you lost consciousness? Were you hospitalized overnight? Just try to find out a bit about the medical damage that happened. And that's rated on a scale of 0 to 5, with 0 being very minor physical damage, up to severe physical damage with intensive care, comatose, etc. And then a final question was added. This is the potential lethality question. And that's where if they have made an attempt and there was 0 physical damage, medical damage, then you will fill out this box with the answer to the question, if they were to try this again, what is the likely outcome? And this was put there because the authors realized that if somebody did something like put a gun to their head and the gun failed to fire, or lay down on train tracks and got off before the train came, it would look like there was 0 medical damage, but they wanted somewhere to say, look, what they did was, so severe or potentially lethal that if they tried it again, it's likely to kill them next time. So this is scored as 0, 1, or 2, with 0 not likely to result in injury and 2 likely to result in death despite any available medical care.
Have you made a suicide attempt in the past 3 months?
No, not really.
What do you mean by not really? have you done anything to harm yourself?
Well, last month I took a handful of pills because it's like even my parents can't see how much pain I'm in.
Did any part of you want to kill yourself? Or was it 100% to get them to pay attention to you?
I guess a little bit of me wanted to die. Either way, I would have been better off.
Were there any other times you did something like that?
No.
Okay, I see. And in the past 3 months, have you ever started to do something to end your life? But someone or something stopped you before you actually did anything?
A friend of mine took a bottle of pills from me because I was thinking about taking them.
Was there any other time that happened?
No.
Okay. And has there been a time when you started to do something to try to end your life, but you stopped yourself before you actually did anything?
No. Not that I can remember.
Have you taken any steps toward making a suicide attempt or preparing to kill yourself, such as collecting pills or getting a gun, giving valuables away, writing a suicide note?
I wrote a note to my friend telling her that she could have my CD collection if anything ever happened to me.
Is that the only thing you've done like that?
This one time, I put a bottle of pills underneath my pillow. You know, just in case.
So, just those 2 times?
Yes.
Thanks. I appreciate how honest you've been. So, when you took the pills, what happened after that? Did you go to a hospital? Did you seek medical attention?
Well, they were just vitamin pills. So no, I didn't get any medical attention.
I see. Thank you. Let's see if we can get you some help.
Thanks.
So for the behavior section, you'll select all the behaviors that apply, but only if they're discrete behaviors. So for example, if they wrote a suicide note and collected pills and then took all those pills, you wouldn't count that as 3 separate items. You would count that just as the attempt, because we don't want to make people look more densely suicidal than they actually are. But you do document every distinct episode of suicidal behaviors if they happened in different times. And a reminder that it's important to assess for behavior even if there is no ideation whatsoever. So if they say no to the first 5 questions, you still need to ask the behavior question. And that's because we have seen the occasional individual who will say, I never had a thought about suicide in my life, but when I was at that party and I was drunk, I impulsively took a whole handful of pills because I didn't want to wake up the next day. And they don't connect that there was a thought that preceded that behavior. And then finally, we have to listen to what the person believed was going to happen and when they did what they did, and not what we think about the lethality of their behavior. So, for example, we have seen very young kids who have done things like put their head into a pillowcase and say, I'm going to suffocate myself. And, well, they probably don't use the word suffocate, but they say, I'm killing myself. And so we need to take that seriously. If we ignore that because we don't think that it could, really hurt them, then they're going to do something more lethal the next time. Another way that this comes into play is Remember that adolescent girl I told you about who was hospitalized at Columbia? She was a psychotic adolescent, and she had some very serious suicide attempts, but she had one suicide attempt where she ordered so much Chinese food that because she thought she could eat herself to death. And, we need a little bit of humor in this line of work, but it's not really funny because she wanted to die and was desperate. And it was just her psychosis telling her, a different way to kill herself that we wouldn't assume was a suicide attempt. So if you're doing the short screener, these 4 behaviors are all combined into a single behavior question, question number 6, and it says, have you ever done anything or started to do anything or prepared to do anything to end your life? And all 4 of those behaviors have examples on the screener form. Now, the time frame that we assess people in, if you're doing the lifetime recent version, you have 2 columns for scoring, one for lifetime and one for recent. For lifetime, you're looking at the time for ideation, the time that they felt the most suicidal in their life. And that's because Aaron Beck showed that even if it was 20 years ago, the time you felt the worst in your life is the most predictive of whether you'll die by suicide sometime later in your life. It doesn't tell you about predicting next week or today, but it does tell you about your life course. And then, of course, for behavior, you do the whole lifetime number of behaviors. But for figuring out if somebody needs to go to the hospital today, if they need one-to-one observation, you're going to be looking at the past 1 month for thoughts and the past 3 months for behaviors. And so the authors chose those time frames when they were developing the scale after receiving data back and determining that after those periods of time, the risk for a reattempt or another behavior drops by dramatically by more than 50%. And so that doesn't mean that if they had a behavior and it was 3 months and a day ago that you don't worry about them, but they had to develop a recommendation, and this was the most reasonable one. Now, it is perfectly okay to change the time frame. It's flexible in that way. But just remember, if you expand the time frame that you ask about, you also will expand the number of positive, worrisome people who will score as worrisome answers. But it is okay, and some people do that. And we really believe that monitoring is what's critical, and that we ask these questions every time we meet with somebody. And whether that's every month if you're doing outpatient med management, or once a week if you're doing traditional psychotherapy, once a day if you're in a day program, or even on an inpatient unit, they're asking these questions every 8 hours at the change of each nursing shift. And that's because it's as easy as saying to someone, since you were last asked, have you had any thoughts about killing yourself, or have you done any of those behaviors that we went over when you were admitted, right? It's just 1 or 2 questions. You just cover question 2 and 6, and, the majority of the time those answers are going to be no. But to not ask them, means that you didn't assess mental status properly, that you didn't do a good suicide ideation, suicide behavior check-in. Now, what are the worrisome answers? One of the great aspects of the scale is that no matter where you're using it, what the worrisome answers are never change. What changes are the next steps, because you'd have different next steps in a school than you would in an inpatient hospital. But what triggers those next steps, the high, low, or medium risk, never changes. And so that high risk response is a 4 or a 5 on recent ideation. So a yes to question 4 or question 5 from the first section, or any recent behavior. And what this is doing is it's decreasing unnecessary interventions and treatment. In the past, people didn't know what to manage, and so they would hear any kind of wish to die and immediately intervene and rush them to the ER. And what we know now is that that doesn't have to happen. Having these clinically supported questions and their answers provide the best available information to inform your clinical judgment. You do need to continue to use clinical judgment, though, We will never have a perfect system for predicting suicide attempts or who's going to die from suicide until we can read people's minds, and I don't think that we're close to that yet. So for now, we're going to have to continue to use clinical judgment along with the best scientific questions. And you need to be able to override the response that comes through the CSSRS, which is something they do at Centerstone and just about everywhere, because you will have some people who will say no to everything on the CSSRS, and you'll still want them on one-to-one observation. There'll still be other things that make you worry about them. Or you'll have someone who says yes to everything because they want to malinger in the hospital and they don't want to go home, and you'll need to be able to discharge them. So you have to be able to continue to use clinical judgment along with the responses that you get to the CSSRS. And so again, those high-risk answers are 4, 5, and 6 on the screener, or 4, 5, and any behavior on the lifetime recent. And the difference between that 3 and that 4 is that 3 is when somebody says, yeah, I've thought about using my brother's gun, but I would never do anything about it. And a 4 is where they say, yeah, I had planned to do it. I had really wanted to do it, or I'm definitely going to do it, and this is when I'm going to do it and where I'm going to do it and how I'm going to do it. It's the having the intent to act, whether there's a plan or not. It used to be that we thought it was having a plan that was important, but it's actually having the intent to act on a plan that is the most worrisome position for a person to be in. And so we have all kinds of copies of the scale that have those high-risk answers highlighted in red for the individuals using them, and then depending on their setting, they can put the next steps right at the bottom of the form. So this is one that was done for primary care, and it says, you know, for yellow, low risk, it says behavioral health referral. And for red, high risk, it says patient safety precautions, one-to-one observation, escort to, you know, the nearest clinical person. And this is New York State's electronic medical record for Medicaid. And they have the CSSRS built right in. And so if someone says yes to a 4 or 5 in the past month or a behavior in the past 3 months, they get the highest level red suicide warning alert. What's also nice about this medical record is that if they have a worrisome answer ever, they get an orange suicide history that stays on their record form. And that's great because if these patients fall out of treatment, disappear off the grid, and come back in 4 years, whoever their new provider is will know that at some point in their life they have had a risky behavior. The way Centerstone does it is that if you get put into their suicide safe pathway, your name populates in purple all across their EHR, so that if you show up on somebody's appointment calendar, your name appears in purple, and that clinician then knows that you're someone who's in the suicide safe pathway. And this is having a strong impact on care delivery and service utilization. Whether it's police officers knowing the right people to take to the ER, schools knowing the right kids to send to the ER for evaluation, or hospitals knowing who to put on one-to-one, and jails. So this was a look at using the PHQ-9, which is what a lot of people used to use for suicide screening. PHQ-9 is a great assessment tool for depression. But the 9th question, which is the suicide question, says, in the past 2 weeks, have you had thoughts that you would be better off dead or of hurting yourself in some way? Now, better off dead is not considered suicidal at all by researchers. It doesn't convey any risk. And hurting yourself in some way can be non-suicidal self-injury. So when Cleveland Clinic looked at 523 patients using these instruments, they found that 24% endorsed that 9th question on the PHQ-9, and just 6% had a positive screen on the CSSRS, where the CSSRS actually picked up a few people that the PHQ-9 completely missed because PHQ-9 question doesn't ask about any actual, of the behaviors. And so this is what Reading Hospital reported, that they have seen one-to-ones in their ER stay below the level they were at before they started screening with the CSSRS. The red line is, the average of where their one-to-ones were before, and the blue line is what their one-to-ones were in the quarters in the year and a half after starting screening with the CSSRS. And you see they had some spikes in identification. They told us those were tough times in their community. And so the CSSRS, we think, did what it's supposed to do, right? When stresses were increased, more people who had their coping skills overwhelmed became suicidal, and they were found and put on, observation. And, using the CSSRS helps protect against liability, both internal and external. Crane's New York magazine did an article on the CSSRS, and they interviewed a medical malpractice attorney and said, do you have any protection if you start asking these questions? Because people have said to me, I don't want to ask because I don't want anything bad to happen. And what the attorney said was that, if you ask these particular questions, which are considered the gold standard and the most scientifically supported, that's the best protection you can get. Right, we're in a mental health field, and so we have some liability no matter what. But when you're using what's considered the scientific top, that's the most protection you can get. Someone at a training we were at said, people don't get sued when bad things happen. They get sued for negligence or malpractice when they don't do something. And a social worker in the Navy where we were training said, we worry a lot inside about our patients, and knowing that we did a good evaluation and used what's considered the best thing out there gives us internal relaxation, right? Allows us to sort of relax inside. That's that internal liability because we hold ourselves accountable when bad things happen. Now, the CSSRS comes with lots of different toolkit items that you can use. We have a pediatric and cognitively impaired version of the scale, which is the exact same scale, but it changes the way the questions are worded so that people with a very, very young cognitive age can better understand them. So, for example, it says, make yourself not alive anymore in addition to kill yourself. It doesn't have, wills on it because, very young kids tend not to write wills. But it asks essentially the same questions, and so it's a good idea to have on hand in case you want additional ways to ask people. But you can also take our questions and copy and paste them into your own evaluation tool that you're using. This is a nurse's mental status exam from a prison in California. They took the CSSRS questions, copied and pasted them into their mental status screen. And this is a cover page of risk and protective factors that the National Guard wanted to know about for their soldiers. So what legal troubles, financial troubles, how many deployments did they have? Do they have drug or alcohol use? Are they in chronic pain? Risk factors that they felt would help them make a decision. And Tennessee decided that for their crisis assessment tool for the whole state, they're going to use the short 6 questions of the CSSRS, and they're going to combine that with our cover page of risk and protective factors because they want to know that they got all the information they could get about family history and current losses so that they could make the most informed decision that they needed to make. Innovation on the scale, the way it's delivered is happening all the time, from people who make laminated cards with the questions on them to keep in their pockets to the ACE cards that I told you about earlier. A couple people actually now are working on phone apps, which we hope to roll out at some point, so keep an eye on our webpage for notice that that's happened. But it doesn't have to be high-tech. This is a poster from an Army Reserve where it said, have the courage to help a buddy, and had the CSSRS questions on it. And it says, if you feel yes to any of these questions, go see your chaplain or your director of psychological health. Some kids in schools have made these and put them in their cafeteria with pictures of the guidance counselor on them, so that they can help their friends.